We will have the oral presentation free paper session now. I call upon Dr. Vidya Shankar, candidate number 1, for his presentation on chemoport.
Doing a study on chemoport as a safe chronic access device in pediatric oncology patients. A surgical audit from a tertiary care center. I am from the Department of Surgical Oncology, KMC Manipal. Central venous access devices like chemoport and Hickman line are reliable long-term access devices. And the most commonly used in the pediatric population is the Hickman's line because of its convenience. So the use of chemoport as CVIDs in pediatric population is less practiced. Our aim is to access the peri-procedural outcomes, safety and complication rates of chemoport insertion in pediatric oncology patients. Coming to materials and methods, we did a retrospective analysis conducted in pediatric oncology patients, and our study duration was from June 2019 to April 2015. So the population, we had a total of 175 pediatric patients, and data was collected from the EMR and the patient files. The data gathered include patient demographics, diagnosis, indications for CVID insertion, type of CVID, duration of procedure, insertion site, technique, and peri-procedural outcomes. The procedure was done under ultrasound guidance. Standard Seldinger technique was done. There was a protocol-based standardization in the insertion, maintenance routines, and trained staff. Coming to the result of the study, so out of the 175 patients, most of the patients underwent chemoport insertion, and the other patients underwent Hickman's line and subclavian line insertion. So coming to the with less than 1 year of age group, most of the patients had chemoport insertion despite the younger age group. So none of the least number of patients underwent subclavian insertion, and the next number was in the Hickman's line. So mean duration of the procedure was almost the same. So in the chemoport it's 30 minutes. Hickman's and subclavian was 25 and 20 minutes. And it included both solid malignancies and hematological malignancies, and most were inserted in the chemoport. And in almost all the cases, we inserted on the right IJV, and except in one cases, we had to insert the chemoport on the left IJV because of the right cervical lymphadenopathy. Coming to perioperative complications, so none of the Hickman line and subclavian line patients had complications, and total 6 complications were observed in the chemoport insertion patients, out of which 1 was intraoperative and 5 were postoperative. So the intraoperative patient had a guide wire associated atrial rupture. So CTVS team was called, emergency thoracotomy was done, and right atrial repair was done. So the patient was discharged on POD7. Among the postoperative complications, 2 patients had pneumothorax, so managed by ICD insertion, removed on POD3. And postoperative site infections, 3 patients, managed by IV and oral antibiotics. So almost all the patients had uneven post-operative recovery and timely discharge. There was no delay in starting the chemotherapy. So all complications were managed without delaying the chemotherapy. So concluding, chemoports are safe and effective for long-term venous access in pediatric oncology with low peri-procedural complications, and it can be adopted more widely in pediatric oncological practices.
Good, you finished very early. So in chemoport, compared to other access, that is PICC line or Hickman, what advantages it gives for children? It's a pediatric population, right?
Yes, sir. So one is the comfort, sir. They don't have a line coming out of the chest. So they can play, they can maintain the regular activities. And maintenance is also easy.
What regimes are in pediatric oncology protocols that differ from adult oncology? Are you aware of what is the protocol length for pediatric tumors?
Sir, it's usually for a shorter duration of time. So,
okay.
Good job, Vidya Shankar. What's the average French size you have been using? I think 113 patients were 1 to 10 years?
6 French we use, sir.
So universal for all the pediatric patients?
Yes, sir.
Same?
6 French, open-ended catheters.
Right. Any catheter fractures in between?
No, sir.
No catheter fractures at all?
Sorry, sir?
Catheter fractures.
No, sir. We didn't have any catheter fractures.
Okay. And your average follow-up duration is?
1 year, sir.
1 year.
1 year.
And subclaves were 11.
IJV, right IJV?
Subclavians.
Subclavian, sorry, sir. Subclavian will be removed early, sir. Subclavian and Hickman's.
No, subclavian you had 11 in number. Did you notice any catheter fractures in them?
No, sir.
You
We
didn't
didn't have
come
catheter
across.
fractures in subclavian also.
Okay. Good. And port extrusion.
No, nothing was, like, except for the infection, we didn't have any other complications, sir.
Right. Thank you.
Thanks.
A very good morning, respected teachers. I'd like to take this opportunity to first thank the organizers and the scientific committee for giving me this opportunity. Actually, I had requested a poster presentation, but now I'm here with the oral presentation. Very, very grateful. So I'm representing the Oncology Disease Management Group at Tata Memorial Hospital, the Department of Surgical Oncology. Basically, this presentation is our analysis of the immediate post-operative complications in around 300 post-chemotherapy retroperitoneal lymph node dissection patients over a period of 11 years. And yeah, this is a single center experience. Now, we all know that in advanced germ cell tumor patients, after they receive chemotherapy, if there is a residual nodal disease, especially in non-seminomatous germ cell tumors, we perform a retroperitoneal lymph node dissection. This is the mainstay of management, and this is done especially when the tumor markers are normalized. Now, this is a challenging surgery, and across literature we have noticed that outcomes vary, and we have seen that centers with a higher load of cases tend to manage patients better intra-op and post-op. So what we tried to do was we tried to look at the incidence of the 30-day major complications in our post-chemotherapy RPLND patients. So this is therefore a retrospective analysis, and therefore this is also our limitation because we had to go back and look at data. There could have been some data that have been missed out with respect to complications. So upfront, I'd like to bring to notice that yes, this was one of our limitations. We analyzed 300 patients between 2012 to 2023. So at our center, we perform post-chemotherapy retroperitoneal lymph node dissections for all residual nodal masses, which are 8 to 10 millimeter in size. And this is with respect to non-seminomatous germ cell tumors. For seminomas, which form a very small percentage of our post-chemo RPLND, obviously the algorithm is different. Yes, we did collect data for clinical pathological characteristics. That data is being analyzed, but I would like to stress on the complications that we saw. Broadly, they were divided into two groups: low grade, which involved the Clavin-Dindo grade 1 and 2, and the high grade, which were 3 or more. The stage at presentation in our country, we see higher stages of germ cell tumors. Not only higher stages, even the risk stratification shows that most of them are poor risk. So this pie chart shows that most of our patients that we treated were stage 3C. So of the 300 patients, like I showed in the pie chart, 30.2% of patients had 3C disease. And if you're looking at the IG, CCG, CCCG classification, with our patients, good risk patients were 35%, poor risk patients were 31%. So the majority were intermediate and poor risk patients. We performed a bilateral template RPLND for 92.4% of our patients. So the median duration of surgery was 360 minutes and the mean blood loss was 750 ml. We required a vascular surgeon's assistance in 8% of our patients. And as we can see, the nodal burden post-chemotherapy was still quite high in terms of size. We were dealing with N3 disease all the way. Now, the incidence of post-op 30-day complications, if you're looking at 4A and above, they were, I'm sorry, if you're looking at 3A and above, they were less than 20%, less than 15% to be frank. So if you're looking at data that is outside international data, stage 3 and above CDC complications rate were around 14% in some of the literature. So what we would like to emphasize is that yes, low rate of complications despite a high burden of disease re-emphasize the importance of centralized care for this rare cancer. I'd like to summarize or just leave this chart on the screen showing what were our complications. And the most common one was a chyle leak, most of which were managed conservatively in the post-op period with fat-free diet. These patients were sent home with a drain, asked to come back to our outpatient department a day before with a fat challenge. But only one patient required an interventional radiological procedure where sclerosant was used. As far as demographics are concerned, Thank you, sir.
You have a few more slides?
No, sir. No, sir.
This is the last slide of yours. You want to conclude?
Yes, sir. So my conclusion, yes, patient-related factors and tumor-related factors do play a role, but what we saw with our raw data that we have analyzed is that experience centers do provide better care in the post-operative setting for these patients. Yeah, thank you.
Any of the inputs, like I think I may missed it out, the various modules of RPLND, like
Yes, sir.
template. Did you have any complications changing over that?
Sir, actually we performed bilateral RPLNDs for most of our patients, and because most of these patients were patients having high nodal burden, we could not perform nerve-sparing RPLNDs for most of these
You have
patients.
not taken prophylactic surgeries. You have not done actually, that's what I understand.
I'm sorry, sir, prophylactic.
No. Sometimes we do prophylactic surgeries without high burden. That is not done in this study.
No. Because most of our patients are high-risk patients or patients with advanced stage, they require chemotherapy, sir.
Dr. Jeffrey, good presentation, good analysis.
Thank you.
300 cases over 11 years. So that average is around 30 in a year. That's a good data.
Yes, sir.
And vascular resections, or it was just an involvement of a vascular surgeon?
Sir, they were not vascular resections. They were vascular cover for possible inadvertent injuries that we may face.
Okay, in anticipation.
In anticipation, sir.
That was for 8%. But at any point in time, you had an inadvertent injury?
Sir, yes, sir. In the last slide, I've mentioned that we encountered 4 vascular injuries, and they were basically common iliac arterial injuries. And there was 2 patients who had a renal arterial injury, which required repair, sir.
So have you analyzed your data looking at patients who had multivisceral resections, vascular injuries as a separate component, and their clamidin grading? Is it higher or is it the same?
No, sir. We've not yet looked at multivisceral resections separately, but we intend to do that, sir.
Maybe you need to factor in so that your complication rates will come down.
Yes,
you have
sir.
a subset only where you can focus in.
Yes, sir. So most of the multivisceral resections are done in a staged manner, sir, because they require pulmonary resections or lobectomies or metastatectomies. So when these patients come to us after our MDT, it depends upon the intra-op course sometimes.
No, what I meant is RPLND with adjacent organ. Could be an ureteric involvement. Unlikely, but in a scenario where ureters are involved, you're not able to achieve a R0, would you have sacrificed a kidney in those aspects? One.
Yeah.
And 66 was your chyle leak rate, right? 66 patients.
Yes, sir.
So how did you manage them?
So these patients, after they are started orally, so we keep 2 drains, sir. We keep a Jackson-Pratt drain in the retroperitoneum and a pelvic drain. The Jackson-Pratt drain is placed closer to the renal vessels. If that turns chylous,
You manage them conservatively or
Yes.
intervened?
yes, we manage them conservatively, sir.
Conservatively, the tubes in place for how long?
Yes. So, sir, these patients tend to go home by day 7. If their drains are chylous, we discharge them with drain. Especially, we keep the retroperitoneal drain in place. We ask them to come to our outpatient department within 5 to 7 days. They are discharged on a fat-free diet. If just prior to coming to OPD, we make sure that they take a full fat diet or a fat challenge.
So prolonged drains, you label them as clavin 2 or 3?
2, sir.
You labeled it as 2? Okay. Shouldn't be, it's a deviation from a normal course, so it goes into the
Goes to 3, yes.
3. Give it a thought.
Yes, sir.
Good presentation, good analysis.
Thank you, sir.
Good morning, everyone. Today's my topic would be a little bit apart from whatever we were discussing right away, because it's more of a molecular basis of cervical cancer detection and treatment monitoring. The topic being diagnostic accuracy of human papillomavirus circulating tumor DNA in cervical cancer patients, a systematic review and meta-analysis. So coming to circulating free DNA, as commonly it is known, circulating free DNA are actually obtained from the cells undergoing apoptosis or necrosis due to the action of scavenging cells like natural killer cells, which cut the DNA which is not wrapped around the histone protein. And as we all know that 99% of cervical cancers are caused due to HPV infections, and HPV tends to integrate into the human genome. That's why we thought that taking HPV as a biomarker and testing its ability in the liquid biopsy test would be a better way of diagnosing cervical cancer in patients where most of the time tissue biopsies cannot be availed, or there are risks of tissue biopsy, like patients can come up with severe infections, or there are chances of bleeding and other cases. So based on the source of liquid biopsy, the tests can also differ, but the very common test being the PCR-based test like the qPCR or the digital PCR or a NGS analysis. For this, we studied the available literature and identified records from PubMed, Embase, Chenal, Scopus, and Cochrane, and a total of 50 titles were screened, and from them we only selected 20 studies for the qualitative analysis. Among these 20 studies, only 12 studies qualified for diagnostic meta-analysis because they had both sensitivity and specificity defined in their studies, and only 6 studies were qualified for prognostic meta-analysis. So when we did a diagnostic meta-analysis, the overall sensitivity of HPV circulating tumor DNA for the detection of cervical cancer was quite a bit low, that is 0.51, that is 51%, but the sensitivity was, the specificity was quite high, that is 95%. So we thought if the sensitivity is that low, then we should not go forward with HPV as a diagnostic biomarker, but a challenge, like something was there we wanted to explore. So when we went through all these studies, we noticed that all the studies have tried different methods for detection, and when we segregated different types of detection methods, we could see a drastic change in the sensitivity, which was reported by different other types of detection methods. For example, when we segregated all the studies with qPCR, you could see the sensitivity was only 19%. Whereas when you're using a droplet digital PCR based method, the sensitivity rised up to 76%. And HPV-seq, that is an NGS based method, showed the highest sensitivity of detection, that was 90%. So obviously when you're considering HPV-seq, you have primers across the whole HPV, and there are chances that the whole part of the HPV comes to the bloodstream and you pick them up. But in the case of digital PCR, though it is a very sensitive method, the sensitivity was quite lower because the primers are usually designed at the E6 and the E7 region of HPV. We made a summary receiver operating curve, that is SROC, and we could see that most of the cases slide on the upper quadrant. That means these studies, the AUC, the area under curve was 0.96. That means the study was more sensitive. We also saw that people had collected prognostic samples during the treatment, after the treatment, and during the follow-up. So we wanted to know which actual time point could be considered for checking the follow-up or checking the prognostic value of HPV ctDNA, and we could see that the hazard ratio of blood sample collected post-treatment was 4.6, that is more than 3, so it can be considered high. When we considered the hazard ratio of post 3-month follow-up, we could see it's much higher, that is 8.5. So to conclude all this study could indicate that HPV ctDNA can be an accurate, sensitive and specific biomarker for detection of cervical cancer. But the clause being, we should use a more updated method like NGS or a digital PCR, and the combined hazard ratio, that is 5.91 or 8.5 at 3 months post-treatment, could suggest that a 3-month follow-up or a post-treatment sample could significantly show which patients are going to have a relapse during the course of time. Thank you.
This is a qualitative test or a quantitative test?
Sorry?
Quantitative or qualitative?
Qualitative.
Qualitative. Okay, so qualitative sensitivity is okay, but for prognostic, just detection is also enough, is it? Presence of this one?
For the hazard ratio, for the hazard ratio, we just saw where the, like whenever there is a rise in HPV copy number. So there was no exact value for cutoff.
Okay.
So, is it useful in metastatic disease?
So metastatic cases, you would always have a HPV copy number very high, and people always get a like palliative care, which is not very curative, I feel. So would not actually have any impact on this, but early detection cases it would obviously have. Like in SIN3 and stage 1, you would get like once HPV is integrated, you would get some fragments of HPV. Also, these tests could be adapted to different other mutations which are prominent in certain stage. Like for example, the PIK3CA mutations, you could do circulating free DNA on them also.
Good morning everyone, I am Dr. Shihana from Sri Shankara Cancer Hospital. My topic for today is bile cultures and post-operative drain amylase and its impact on post-operative complication post-pancreaticoduodenectomy. Pancreaticoduodenectomy is a standard intervention that we do for benign and malignant pancreatic lesions. However, it is associated with significant post-operative morbidity from 30 to 60% with a mortality rate of 3 to 5%. Bactobailia is the presence of bacteria in sterile bile duct and gallbladder, leading to various clinical implications, most importantly associated with post-operative infectious morbidity. However, the precise impact it remains uncertain due to disparities in the existing literature. Also, drain fluid amylase can serve as a valuable indicators for all these morbidity, most importantly being post-operative pancreatic fistula. There are multiple scoring systems, but the scoring system that I've taken is POPF grading of biochemically grade A and grade B and C, which is clinically relevant. Along with that, another risk stratification score as well. The Clavin-Endo classification is how I've based my post-operative complications, that is based from grade 1 to 5. Here, the study was aimed at evaluating the predictive role of different risk factors, including positive bile culture and value of amylase in post-operative complications. Inclusion criteria include adults aged 18 years underwent pancreaticoduodenectomy between January 2020 to April 2025 at Sri Shankara Cancer Hospital. Exclusion criteria was below the age of 18 and when we couldn't collect the bile culture sample. So 93 patients underwent pancreaticoduodenectomy. The data collection was done based on demographics, comorbidities, and all the other details, and microbiological analysis was done as well. Coming to my results, the most common age group was between 60 to 70 years. Comorbidities, diabetes, and hypertension being the most common, males more common than females. Coming to the tumor site, the most common was periampullary, followed by head of pancreas. Symptoms, jaundice 48% most common, followed by pain abdomen. And these were the patients who were stented and not stented patients. Histopathologically, T2N0 and T3N1 were the most common. Surgical technique was Bloom-Gut and modified Heidelberg for the most, and then ductomucosa 8%. Now coming to the bile culture results, there were 53 patients out of the 93 who had positive bile cultures. The organism most common being Klebsiella, that is 31.2%, followed by E. coli 20.4%, then followed by Enterococcus, Pseudomonas, and Enterobacteries. This is the division of all my post-operative complications based on Clavin-Endo classification. There were 24 patients who had post-operative complications. This is the division based on positive and negative bile culture growth. So here we can see that there is a p-value of 0.003 which showed a significant correlation between bile culture and the post-operative complications. The complication rate based on bile culture organism, E. coli showed the most common complication rate, followed by Klebsiella, even though Klebsiella was the most common. The antibiotic sensitivity that we found in our hospital was most common was amikacin, tobramycin and gentamicin, which goes against few papers which say that piperacillin and tazobactam is the most common one used. There was a subset analysis that we did which again showed that there was a highly significant p-value showing complications there most in positive cultures. This was based on the fistula grading, drain amylase and also risk score, all of which showed significance in positive bile culture when compared to that of negative. For drain amylase, Spearman correlation for drain amylase was positive in both, which was strongly and statistically significant. Post-operative stay was also calculated, the mean stay being 13 days, which was also showed a p-value of 0.08, but this was not clinically and statistically significant. But the positive culture had a slightly higher value. Coming to my discussion, the bile culture was positive in 57, most common organism being Klebsiella, and the p-value was significant in most of the post-operative complications. To conclude, bacterbilia is more common in hepatobiliary surgery and associated with increased risk of perioperative complications, and taking intra-op bile culture is a simple and cost-effective method that allows targeted interventions to reduce the risk of infection. To consider the correlation between bile culture and post-operative complication, preventive measures like prophylactic antibiotics can be considered, and we can also predict the post-operative complications as well, and we can also include this as in our scoring systems also. That is my conclusion. Thank you.
So I have to just, one of your conclusion was actually antibiotics have to be considered. But haven't you considered antibiotic pre-operatively?
Yes, preoperatively, we, based on the antibiotics here, sir, we priorly based on other studies that have been there, cephalosporins and piperacillin, tazobactam was the most common ones that we use.
No,
but in my study,
asking for a change of antibiotic.
yeah,
Change of antibiotic.
yeah.
You were not specific there.
Okay, yes, sir.
So 43% were with obstructive jaundice.
Yes, 48%, yes, sir.
48. And how many were stented?
Out of the jaundice patients, sir, 25 patients were stented, sir. 25 were ER, so 35.
Percentage-wise?
Yeah, prior to the surgery, 35 were stented and 4 were PTBD, sir.
No, if you could break it into percentage, 48% is your obstructive jaundice patient.
Yes, sir.
How many of these 48% were stented? Is it 20%, 30%, 50%? You looked in like that, or?
No, I have not
Overall,
done
you're
that.
giving
Yeah,
one.
overall the stenting percentage.
So have you noticed any difference between stented and post-stented is relevant for us?
Yes, sir. The thing is, I got the statistical evaluation for that. The p-value was 0.7, sir. It was not statistically significant based on positive culture and this thing. There was an increase in the culture positivity, but it was not statistically significant, sir, compared on stented and non-stented.
So what are you proposing through this? Your analysis, you have done an analysis.
Yes,
what
sir.
is the outcome?
I want to include the positive, to make sure that intraoperative drain culture, bile culture is done for all the patients, and to see if we can stratify it as a score in part of our scoring system, and to make sure, and to also see that there is an increased chance of complications if we get a positive bile culture when we are scoring it, sir.
Right. And what's the hospital policy after this analysis at your place?
We have not yet started now,
You're
sir,
yet
but
to
we
implement.
do. Yeah, we are yet to start, but we do intraoperative bile culture for all patients now, sir.
Okay, right. Thank you.
Yeah.
Good morning, everyone. I'm Dr. Varun from KMC Manipal. Good morning, everyone. I'm Dr. Varun from KMC Manipal. I'll be presenting my paper titled Textbook Outcomes Following Esophagectomy, Initial 100 Patient Experience at a Southern Indian Tertiary Care Cancer Center. Esophagectomy is always considered surgeon's Achilles heel, considering the complexity of the procedure and the challenges we come across in the post-operative recovery. Perioperative outcomes is described as textbook outcomes by Dutch Upper GI Cancer Audit, DUCA. It consists of 9 variables. Updated textbook outcome, there are 9 variables, including R0 resection, retrieval of more than 20 lymph nodes, no intraoperative complication, no hospital readmission, no hospital stay more than 14 days, or no hospital mortality. There are 9 variables. Aim of our study is to conduct surgical audit of first 100 esophagectomies and to determine textbook outcomes of esophagectomies in our center and its influence on oncological outcomes. It was a retrospective cross-sectional analysis. Data was sourced from electronic patient database maintained prospectively. Study duration was between Jan 2019 to April 2024. All patients who underwent esophagectomy during this study period were included. And post-operative outcomes were measured with respect to updated textbook outcome variables defined by DUCA. Statistical analysis was done by Kaplan-Meier curves, and Cox regression analysis were used to correlate survival outcomes. Total 100 cases were performed. In that, majority were McKeown's approach with cervical anastomosis. And in that, 48 are minimal invasive VATS. In that, 30 cases are purely minimal invasive VATS plus laparoscopic approach for abdominal part. And 38 were open among McKeown's. And 10 were transhiatal, 1 Ivor Lewis, and 1 was left thoracoabdominal, 2 were left thoracoabdominal approaches. Total, we achieved textbook outcome in 42 number of cases. When we compare minimal invasive approach and total and open approaches, achieving 22 in minimal invasive, we achieved in 22 number of cases, and in open approach, we achieved in 20 number of cases. It's almost comparable. But if we see complications, clavin endo complications, grade 3 and above, we had 9 cases in open approach and 5 cases in minimal invasive approach. So most of these were pulmonary complications, and anastomotic leaks, it's comparable, 9 in both open and minimal invasive approach. R0 resection, it is equal in open and minimal invasive, and retrieval of lymph node, it's equal in both the approaches. When we see survival outcomes, when we compare survival outcomes in patients with textbook outcome and without textbook outcome, disease-free survival was marginally better in patients with textbook outcome without statistical significance. When we see overall survival, it was significantly better with patient who achieved textbook outcome, with mean overall survival of 46 months versus mean overall survival of 26 months without textbook outcome. When we compared survival functions in anastomotic leak patients and patients with nodal positivity on histopathology, survival outcome was better in patient with anastomotic leak, and even nodal positivity had a significant impact on overall disease-free survival. Disease-free survival was, mean disease-free survival was 46 without nodal positivity, and disease-free survival was 17 months with disease-free with nodal positivity. And when we see complications, patient who had clavin endo 3 or more complications, they had poorer survival compared to patient who had no complication. And when we see overall survival in patient with and without textbook outcome, median overall survival was 34 months and 10 months without textbook outcome. When we compare the textbook outcome in our center over the years, there was a dip in achieving textbook outcome. It was 22 and 26% in 2020 and 2021, maybe because of COVID. And over the years, we have improved, and in 2024, we achieved 57% of textbook outcome. If we compare with world standards, it is based on different studies, it shows 31 to 47%. And in our study, in our center, we have achieved 42%. So we are in par with the world standard. So I conclude by saying standardizing perioperative outcomes of esophagectomy and achieving textbook outcomes help in improving oncological outcomes.
This with respect to Kaplan-Meier survival curves, actually there are significant drops in one of the, like for example, node positive and so, I mean, what is the purpose of identifying an individual component with outcome?
So
There is a significant, like for
with
example,
respect-
node positive, node negative, anastomotic leak. There is a huge drop in the beginning only. I think possibly because of early mortality. If you look into the...
Yeah, we compared every complications, are all variables we have compared. Important findings and important ones I have put here.
Good work, Varun. Can you go back to your first slide?
Yes.
So year on year, you have analyzed, right? Regardless of if you have to factor in your lymph node and resection margin status.
Yes, sir.
So how was it the trend in 2020, 2021? 40% was in 2019 and then you said there was a dip.
That is achieving overall textbook outcome.
Yeah, so I'm just saying you have to look in, you have to factor in each component instead of saying everything together.
Yes, sir.
You have to see how much was the lymph nodal yield for that year. You have not...
No, we have done, but I have not put everything. Lymph node retrieval has increased, it has been improved, sir, over the years.
Yeah,
It
as
has
you
improved.
add volumes to your work, the number of nodes which are harvested, your R0 resection improves.
Yes, yes.
So I think you should look into that also year on year.
Yes.
Instead of saying it, it's just the COVID which made it difficult. Yeah.
Yes.
Good, liked it. And how many of them were post neoadjuvant chemo-RT?
Here, most of them, 90% of the cases were post NACTRT. Most of them are squamous cell carcinoma. Very few are adenocarcinoma. So,
And average hospitalization is approximately?
average hospital stay is 7 days, sir.
Good morning, everyone. My study is to study the effect of neoadjuvant therapy on lymph nodal yield in gastric cancer. So, lymph nodal metastasis is an important determinant of disease progression in patients with gastric cancer. So, the lymph nodal yield is the number of lymph nodes retrieved during oncological resection and histopathologically identified in the resection specimen. It is an important surrogate parameter for assessing the oncological radicality of the resection of gastric carcinomas as well as a prognostic factor in these diseases. For patients with localized resectable gastric cancer, NCCN guidelines recommend gastrectomy with a modified D2 lymph node dissection with the goal of examining 16 or more lymph nodes. So the primary aim was to study the effect of neoadjuvant therapy on the lymph nodal yield in locally advanced gastric cancers. The primary endpoint was the number of lymph nodes identified in the resected specimen, and secondary endpoint was the number of positive nodes, recurrence rates, and survival outcomes. So this was a retrospective analysis of all the cases operated over a period of 3 years from 2020 to 23. The patients were followed up for a period of 12 months. Patients underwent staging via contrast-enhanced computed tomography of the chest, abdomen, and pelvis, and upper GI endoscopy. 1/3 of these patients received perioperative chemotherapy, and the most common regimen used was FLOT, followed by ECF and CAPOX, and these patients underwent curative resection 1 month post-chemotherapy. The 2/3 of the patients were treated with curative resection alone, followed by adjuvant chemotherapy. All these patients underwent curative surgery with adequate margins, and D2 dissection was ensured in all of these cases, and D2 bed was documented. Coming to the demographics, there was no significant distribution, no significant statistical difference between the age and the gender distribution in both. The most common site of disease in both the arms was distal, and the most common histology that we saw was pure adenocarcinoma followed by signet. The most common type of surgery performed in both of these arms were distal gastrectomy followed by total gastrectomy. Then we look at the T stage. The T stage distribution remains almost same, but when we see the T4, we see a lot of upfront cases rather than post-chemo. Then when we look at the YN stage, there is a lot of N3 disease in the patients who underwent upfront surgery, whereas there is a lot of N0 in the patients who underwent surgery post-chemotherapy. So looking at our primary endpoint, the average lymph nodal yield, in the upfront arm, it was 20.75 versus 16.75 in the post-chemotherapy arm. And we compared this average lymph nodal yield in various histologies as well. And we found that in all these histologies, post-chemotherapy, the lymph node yield decreased and it was statistically significant. To overcome the problem of stage migration when the lymph nodal yield was less than 16, we incorporated lymph nodal ratio, and this also decreased upfront in the post-chemotherapy arm compared to the upfront, and similarly when substratified according to various histologies. Now we correlate the lymph nodal yield and the recurrence. We see in the upfront arm, as the end stage increases, the recurrence rates increases. But in the post-chemotherapy arm, the N and the recurrence value is not correlating. This is probably because of stage migration, and we have to correlate using lymph nodal ratio rather than the end stage. So there are multiple studies conducted for gastric cancer by Wu and Dicken et al., in which the lymph nodal yield did not decrease post-chemotherapy versus upfront compared to our study. But there have been other organ systems, especially the rectum and the breast, where post-chemotherapy the lymph nodal yield has decreased compared to upfront surgery. The limitation of our study was we should have backbenched the specimen along with the pathologist in the operating room to confirm whether the lymph nodal yield decreased. So, concluding my study, this retrospective study investigated the impact of neoadjuvant chemotherapy on the number of lymph nodes harvested. The number of metastatic lymph nodes that we isolated was an independent predictive factor for recurrence. When the yield decreases, it is much more feasible to use lymph node ratio to avoid the problem of stage migration. With evidence that neoadjuvant chemotherapy decreases the number of lymph nodes harvested, the threshold of what constitutes an adequate assessment should not be the number of nodes harvested, rather it should be the completeness of D2. So therefore, before we modify the post-operative management, it is imperative that you get back to your surgical oncologist and confirm whether an adequate D2 was done, not just based on what the lymph node histopathology report says. Thank you.
Have you compared it with the pre-op imaging?
Yes, sir.
Findings of pre-op, like clinical staging, I am reasonably certain T-staging might not have been done, but have you correlated with the end staging, clinical end staging before pre-treatment?
Yes, sir. Most of those upfront arms were T4 N plus disease. There was significant downstaging seen, especially in the pure adenocarcinoma arm, when we compared the pre-op staging.
So, to have a prospective study, similar, what are the issues you'll be thinking? If you do a similar study,
Yes, sir.
so why can't you do a prospective study?
Sir, prospective or a randomized would be better, but most of the gastric cancer that present to us are usually an emergency case with either bleed or obstruction, and then those end up usually having an upfront surgery.
You can have prospective cohort study or observation study. You don't have to randomize.
Correct, sir.
Thank you.
Rajeshwari, go back to your one of our slides. I think we were comparing N1, N2, N3.
Yeah, 1 second, sir. Yes, sir.
Out here, what's the inference you're trying to put out?
Sir, these patients in the pre-op imaging, especially in the post-chemo arm, were N plus diseases. Now we see that post-chemo, when we have operated, there are very less number of patients with N3 disease. And even if they remain N3 post-chemo, this suggests an aggressive disease biology and that they were going to fare worse.
So you mean to say there were 28 patients with N3 disease?
Yes, sir.
And you have 4 patients with N3?
Yes, sir.
And 16 in N2 and 7 in post-chemo?
Yes, sir.
So this is not an ideological comparison, right?
Correct, sir.
You have 28 patients with high volume disease,
Yes, sir.
untreated. We cannot draw conclusion that post-chemotherapy, the nodal yield has decreased.
Yes, sir. So that is
But
the main...
theoretically, yes.
Yes, sir.
Post-chemotherapy it decreases, but
Yes,
I don't
sir.
think we can draw conclusions by matching this.
Yes, sir.
And recurrence, you're talking about regional recurrence, you're talking about systemic recurrence, or is it both?
Yes. Sir, this were mainly regional recurrences. So what I tried to highlight in this was, we have stratified them as YN1, N2, N3. But the lymph nodal yield was less than 16 in more than 50% of the cases in post-chemo. So what we stratify as N1 and N2 itself is becoming wrong.
I feel there's too much of a dilution.
Yes, sir.
Because you said the FLOT,
Yes, sir.
ECF,
Yes, sir.
K-POX,
Yes, sir.
one, small volumes.
Yes, sir.
I think we need to
Yes, sir.
wait for a time
Yes, sir.
to mature. Yeah? I think, thank you.
Thank you, sir.
Dr. Mari Chaitanya, postgraduate from General Surgery from K-Sector Medical Academy, and my guide is Dr. Vinay Kumar. My topic is today about outcomes of surgically treated patients with non-small cell lung cancer, a single center experience from two-tier city. My background of the study is lung cancer in India is often presented at an advanced stage, and most of the non-metastatic cases requires multimodality treatment with curative intent. And my study is a retrospective study done between 2019 to 2023. The main objectives of the study is to evaluate the outcome of non-small cell carcinoma patients undergoing curative surgery, assessing the role of effectiveness of multimodality treatment, including the neoadjuvant chemotherapy, and it helps in determining the feasibility and success in resource-limited setting like two-tier city. Methodology of this study is, it is a retrospective analysis of patients who are undergoing thoracoscopic surgery. The database is collected between 2019 to 2023, and the inclusion criteria is the patients who have biopsy proven and who underwent whole body positron emission tomography, computed tomography patient, along with mediastinal staging, which is done by endobronchial ultrasound in most of the cases. Patients with mediastinal metastasis who are categorized as N2 and also with extensive chest wall involvement and requires an upfront pneumonectomy received neoadjuvant chemotherapy of platinum based for 3 to 6 cycles, minimum 3 cycles and maximum 6 cycles before going for the surgery. The key findings of this study is a sample size of 24 patients were taken, in which 13 patients have undergone surgery upfront and remaining 11 patients who underwent neoadjuvant chemotherapy with platinum based and followed up by the surgery. And the mean tumor size which was included was 5 centimeter, and chest wall invasion was around 5%. And in non-small cell carcinoma, the histology subtypes mostly were 50% was squamous cell carcinoma and 43% was adenocarcinoma. And while operating surgery, most of 75% went with laparoscopic like minimal invasive, whereas 25% of the surgeries were converted into open. The post-operative, the mean ICU stay was 22 hours with no major complications or mortality, and 10% pathological completion response was achieved for the patient who underwent neoadjuvant chemotherapy, and followed up by a disease-free survival rate for 3 years were achieved in 60% of the population, and overall survival rate was 72%. And patients were divided into non-localized metastatic and localized metastatic based upon the PET-CT as well as endobronchial ultrasounding guided. And patients who doesn't have any local medial lymph node metastasis as well as chest wall invasive directly underwent surgery without any neoadjuvant chemotherapy. Whereas patients who had mediastinal lymph nodes as well as chest wall invasion has underwent 3 to 6 cycles of chemotherapy followed by the neoadjuvant chemotherapy. My conclusion of this study is it is helpful for a patient who has high-grade mediastinal lymph node metastasis, will have a complete pathological curative treatment followed by multimodality treatment. And it favors in outcome in non-mortality and high margin negative resection rates. Thank you.
So you have a PET-CT and then
Yes,
you put
sir.
in a E-bus.
Yes, sir.
So E-bus you're doing it for all patients
No,
is
sir,
what?
not for all the patients, sir. If there is any chest wall invasion, then we are considering for EBUS, as well as if we are suspecting any lymph node in PET-CT, then we are going for EBUS, sir.
Okay, lymph node positive on PET-CT you're doing an E-bus.
Yes, sir.
And all N2 you're giving a chemotherapy? All N2?
Yes, sir. Only 11 patients underwent neoadjuvant chemotherapy, sir, whereas 13 patients we have took directly for the surgery, sir.
So all these 11 patients had N2 disease?
Yes, sir.